I'm Dick Moberg, and welcome to our interview series. A lot of interesting people pass through our doors who are doing amazing work in brain monitoring. We bring them into our studio, put a mic on them, and get the personal stories you don't normally hear. We hope you enjoy them. So we're here at the ACNS meeting, and we're in a bar in the lobby of the hotel, and we run into Brian Appavu from Phoenix
Hello.
Children's. So thanks for taking the time to talk to us, Brian.
Hey, Dick. Great to see you guys.
Cool. Yeah, cool. So at the ACNS meeting, it's a lot of epileptologists here. It's kind of one of their main meetings. It's more research environment. It's a great meeting. I've been a member for years. Love the meeting. And I think what we want to talk to Brian about is Brian's much more sort of right in the ICU with the kids at Phoenix Children's. He's a big promoter of multimodal neuromonitoring. But what you see here a lot at the meeting are epileptologists that go into the ICU, and they bring their perspective to critical care, which may or may not be, the right way to do this. I mean, EEG is probably EEG, but I think you need the gestalt. You need all of these other modalities, and you've certainly done that to the max. I think probably better than most people in the country in a children's hospital. So so what are your thoughts on that, and what do you need in terms of epilepsy, or are there other aspects of EEG that are probably important?
Yeah, no, I think you have a very interesting perspective, and I think a very insightful one. I think as a physician who's trained in epilepsy and has tried garnered skills and done my own sort of work in terms of training in different elements of neuromonitoring and neurocritical care, I can speak at least on the EEG side of things and the epilepsy and clinical neurophysiology side of things, that a lot of things come down to how we train individuals, and so there's a lot of the usually there are individuals who go through a neurology residency training where, depending on where they work, they may have some exposure to neurocritical care. And they may not have that much exposure, just depending on what sort of program they're at. And then they'll move on to, if they really like to read EEGs and they really like brain monitoring, they may do an epilepsy or neurocritical care fellowship. These fellowships are very geared towards, also have very high demands in terms of pre-surgical epilepsy evaluations, so identifying where seizures might be coming from in a patient with epilepsy, and a lot of extensive work on that end. And part of the training also involves ICU EEG. And from an epileptologist perspective, the most important thing that we're monitoring for with EEG has been seizures. So the history of EEG has been, continuous EEG monitoring has been in regards to seizures. And there's a lot of epidemiological data that tells us that seizures are associated with brain injuries, and they're associated with unfavorable outcomes. So the monitoring of seizures and the treatment of seizures has really been at the bedrock of why we do ICU EEG monitoring. So that's kind of where I think the background comes from, where the epileptologist has the perspective of how EEG monitoring is used. Now, that being said, there is the world of neurocritical care where seizures are an important element. They can contribute to brain injury, but there's a lot of other epiphenomena that we can evaluate using EEG that represents secondary brain injury mechanisms. So things like cortical spreading depolarizations, things like cerebral ischemia, and then malignant cerebral edema leading to increased intracranial pressure. And more emergent is concepts of recognizing a patient's having sleep-wake cycling or covert cortical processing of stimuli around them. And these are phenomena that don't necessarily have a whole lot to do with seizures, yet we're identifying characteristics of the EEG that have a direct relationship to these things. And I think as we evolve toward improving brain monitoring, EEG is a really important tool, but I think for those who haven't gotten a lot of exposure to what's important in neurocritical care, they may not be able to fully communicate all the aspects of the EEG that could be important to the primary goals of what neurocritical care is, which is more than just treating seizures. It's to prevent secondary brain injury in all forms that can occur to optimize the best outcome from patients.
Yeah. No, I think that's right. And I kind of got my start in EEG in critical care with, I remember a long time ago, we were looking at staging metabolic comas for liver transplant patients. I mean, that was one of my early things, and had little to do with seizures, but it was all about, looking at how's the brain doing metabolically. And I think we're seeing more and more of looking at that background activity and things like that. So, which I don't think an epileptologist has as their primary.
It's not the it's not the primary question that often is asked. Is not evaluated for, and so that oftentimes might get missed in the description of what findings are reported.
Yeah, and I think the other thing that kind of bothered me was it's maybe a little different now, is when the epileptologist is reviewing the data remotely without a lot of the context of the critical care patient. They could be in a different building and they're really just looking for seizures, right?
Yeah.
And what's your perspective on that?
It's a challenge. Depending on what sort of a work environment an EEG reader is at, they can have a lot of different demands. There can be demands to look at the ICU EEG as well as to look at to read routine studies at the same time, to read, to be involved. At our hospital, I think our clinical neurophysiologists are also involved in intraoperative monitoring. So they're looking at, spinal surgery that are going on top of the EEG that's going on top of the ICU EEGs that's going on, and a lot of the dependency. Even if they wanted to spend a lot of time, usually the workflow doesn't allow them to really spend a lot of time looking at the other elements and what's important, because in brain injuries, seizures are important and seizures are an indication, but there's all the other elements that we want to look for. And I think the challenge also is we've not developed historically. Continuous EEG has been developed in isolation, not with other hemodynamic parameters like intracranial pressure or brain tissue oxygenation, but with some of the technology that you developed in your career. There are now opportunities to get that interface together, where we really can start to look at EEG in relation to physiologic markers of cerebral edema, heart rate variability, blood pressure, cerebral blood flow, and then be able to make those correlations in a way that we really can inform all aspects of clinical decision making. One of the things that I find fascinating in my practice is, with the multimodal monitoring devices that we have, is to hook up, to look at EEG, to look at transcranial Doppler at the same time, and to, work with our intensivists to manipulate ventilation parameters to see if CO2 is optimized or not, to see if test autoregulation to see if blood pressure is optimized or not, and sometimes we can see that our cortical function changes if we lower or raise our CO2, our end tidal CO2, and that influences where our intensivists might want to put tidal volume or respiratory rate. And so these are the type of things that, if you're in another room and you're not really engaged in these provocative maneuvers or tests, and I think you're not really. You're going to see some background changes. You might notice them, and it might be subtle. But if you don't know some of the questions that are being asked, you can't really communicate to it. So, I think the future. I think the future is hopefully one where ICU EEG is really separate from some of the other aspects of EEG monitoring that's in current clinical workflow, like pre-surgical evaluations and routine EEG evaluations for epilepsy. Those require, especially epilepsy surgery evaluations, that requires a lot of demand. Requires a lot of expertise and a lot of training, and that's I think is its own field. And then to a different extent, ICU EEG or ICU brain monitoring, I think just to put it, where it should be, is, that's going to be its own field too. And that has to go in sync with where neurocritical care is going in terms of what are the biomarkers that we're identifying that represent secondary brain injury, what are the treatment parameters and neuroprotective measures we can afford to reduce secondary brain injury, and what type of monitoring we can use. EEG is really fantastic because unlike all of our other brain monitors, an EVD, an intraparenchymal probe in the ICP wire is in one location. A brain tissue oxygenation catheter is in one location. TCDs, you might be lucky to get your MCAs, but that's it. But that EEG gives you data everywhere, the entire scalp. And, you might, for my right-handed kids, that left temporal lobe is very important for language. If my intraparenchymal probe, my brain tissue oxygenation is on the right frontal region, that can be nice, that can be informative, but I want to look at how left temporal function is if I want to preserve language. So, EEG allows me to look at those to increase the spatial resolution of my data and to really help, guide sort of neuroprotective measures. But yeah, definitely to bring it to the next level, I think it requires a different effort in terms of education and skill development, really centered around neurocritical care and the aspects of brain monitoring that have to do with secondary brain injury.
Yeah, it makes a lot of sense. And given the demands of the epileptologists with all these other fields, and the fact that this might be separate, what do you think about automating some of this? There was a great session yesterday on AI and EEG, and what do you think could be automated in the future for maybe not only EEG, but for looking at trends and really helping you put the big picture together and stuff?
Yeah, I think that's a great question. I think depending on how some of the clinical trials are going with PRX and CPP op-guided management, depending on what we learn from that, there might be an opportunity in the future to automate providing guidance about where blood pressure is optimal. I think if we can classify, I think if we can forecast seizures and classify them, we might prepare and then classify who's likely to go into super refractory status after we wean meds or don't. That might be able to guide, some of our clinical decision making. I think that there's opportunity when we do some provocative measures in the ICU to test autoregulation or CO2 reactivity. We might be able to profile physiologic we might be able to create physiologic profiles that, this is a patient who might benefit from pressure-related, CPP op-guided pressure-related care versus the concept of the Lund concept of care, where there might be select patients that benefit from volume reduction of cerebral edema that might improve brain homeostasis. So the ability to characterize different elements of CO2 reactivity, brain compliance, autoregulation, and cortical function, I think those elements can help us break down what therapeutic strategy may work. There's definitely a lot to say about the lack of efficacy of clinical trials in neurocritical care, and I think a lot of that has to do with a one-size-fits-all approach.
Yep.
And I think once we can subcategorize, and that's something I think we learned from in some of the cardiac arrest studies, or some of the cardiac arrest sessions earlier this year. There was the Telstar trial that did not show benefit of treating rhythmic or periodic patterns with anti-seizure medications, but there was some evidence, in the sub-analyses that there may be EEG background patterns that may suggest that certain patients would benefit. And to that extent, it's like, okay, maybe we can find physiologic profiles for certain patients where treatment's going to work, and then we need to maybe tailor those trials or tailor, appropriate studies for a physiologic profile. And that's where we might get, we might show endpoints where we achieve our outcomes we achieve our endpoint to show improved outcomes if we can identify that cohort. I think a great example where this has occurred is stroke. Like you have the Dawn and Diffuse trial. That didn't lose multimodal monitoring, but it used multimodal imaging to look at, okay, in adults who might benefit from a thrombectomy, if you categorize those who have ischemic penumbra and then you select those for a mechanical thrombectomy, several hours out from the injury, that they can benefit from it. The same way, the physiologic profile of some of our patients might tell us who's going to benefit from hypertonic saline to improve outcomes with cerebral edema, or who's going to benefit from early but decompressive craniectomies, or what cardiac arrest patients are going to benefit from therapeutic hypothermia. I think when we can extract that physiologic profile, that may allow us to subcategorize those patients and study them better.
That makes a lot of sense. So one final question. From what I understand, one of the toughest things you have to decide is if a kid comes in a coma, after an action, what do you tell the parents? And I think this whole Curing Coma project is really trying to address that, and I think probably multimodal monitoring and some processing somewhere may help us with that. So what do you have hope that's going to happen? So.
I have hope. I think it's the question is, I have hope that it's going to happen. I think that we're going to be getting to a point where we're using physiologic tests to really understand the degree of to improve our understanding of the degree of capacity that patients have for improved outcomes. I think the question in my mind is how, is not a question of if, it's a question of when. And I think, that to me is, changing a lot of paradigms in a lot of different areas. There's been, one of the things that we face, one example that we face is, what do we do with children that have atlanto-occipital dislocations with traumatic brain injuries? There's been, we've run into a lot of historical resistance in terms of how to address those patients, because there's a lot of people who feel like those patients are, a lot of those patients have outcomes that represent futile care. But many of these patients, just depending on the nature of their injury, may have preserved cortical function in their brain, and they may not have motor. Their capacities for motor function may be limited, but they have so much cortical. Some of them have a ton of cortical function that we have to take a step back. I mean, historically, if you talk to a lot of trauma surgeons, they don't have that much experience with EEG. So when they see a child with an atlanto occipital dislocation, they're the thought is this is going to be a poor outcome, this is going to be an unfavorable outcome, and from a motor perspective, it probably will be, at least at this point with where our technology is. But the degree of brain function that can still be there, when we introduce ourselves and we're like, hey, there's sleep spindles, there's reactivity, there's the pupillometry is showing us that the pupils are reactive, the NIRS is showing us, good oxygen extraction when we stimulate the head, not the arms. This patient may be in there. Right now we still end up, giving these patients, unfavorable outcomes in terms of their motor abilities and their dependency on activities of daily living. But the future might be one where we have neurotherapeutic strategies where we can harness brainwave activity to actually mechanically interact with our environment. And I think that's the future. We deal with these debates in the here and now about how to address these patients in the here and now, and it's super challenging in the here and now. But I think, as I talk to a lot of people, it's like we have to think about the future as well. We have to, even if we give certain recommendations now, we have to be prepared to re-update, how we approach these kind of patients, because the technology is evolving, our understanding of physiology is evolving, our capacity for harness physiology to modulate activity is evolving, and at some point we'll be in a different world. We'll be in a different landscape.
Yeah, that's great. Well, you're truly one of the pioneers in pediatric multimodal monitoring, and it's always a pleasure to catch up with you and get your perspective on things.
Thank you, Dick.
So thank you for the time.
Of course, always love chatting.
Great. Thanks.